what is the utility of TE in an unusual situation, or when you come across a emergency situation in Cathlab or somewhere, that I'm trying to demonstrate. This was a 47-year-old gentleman. Patient was diagnosed case of diabetes, hypertension. He had atypical chest pain, which has increased since last 6 hours. ECG done, showed ST depression and T wave inversion in anterior leads. Consulted a cardiologist, enzymes were positive. He was admitted for CAG and SOS PTCA. EF was 55%, clearly a hypokinesia in the LAD territory. No major issues there. But on coronary angiogram, you can see mid LAD there was a lesion, and there was a lesion in the distal RCA or PD junction. Okay, so for a cardiologist, a very straightforward case. He put a long stent in the LAD. Patient tolerated the procedure very well. There was no issue whatsoever. We proceeded for the PDA or RCA stenting. Okay, this was the first view. You can see something abnormal there. Some bulge of the dye is there. Maybe he's trying to cannulate it properly. And on the second image, is actually running. It's not frozen, it's running, but there's no contrast there. You can see that there's no contrast happening there. So that immediately alerted the cardiologist that something is not right. So they tried to, get through, cannulate the RCA, tried to put in the guide wire. Guide wire was not going somehow. Multiple attempts were made. As you can see, he had put 2-3 guide wires. Somehow staining had started and it was a red flag. They thought that okay, this is going to be very difficult. Meanwhile, patient had an arrest. CPR was given. We had put in a temporary pacing wire. Multiple attempts were done, and finally they said that okay, we call it off. We shift the patient to the OT, do a single vessel CABG, quickly put a graft to the RCA, and let's get out. So he thought that okay, this is half an hour job, so we'll go in, just get out. So when we tried to induce, like I shifted the patient, we induced the patient. It was uneventful, but one VF episode, and something was not right. So I put in the TE probe. You can see. So because it was very very stormy course, I decided to put in the TE probe, and you can see that I'll show it that again. Normally contracting LV, and then this thing. So this was a clear, not the dissection of the PD or the RCA, it was dissection of the ascending aorta. The cardiologist said, I have never seen in 25 years of practice, but that is what it was. They said that okay, we'll try to conserve this, but obviously ascending aorta dissection cannot be conserved. We had to fix it off. But then again, not only TE diagnosed the issue, but TE helped them. So this was very clearly demonstrated in this ascending aorta view as well, that there was dissection. But then came the next thing. What next? So we tried to look for the extent of the dissection. Fortunately, there was no dissection in the descending aorta and arch. So it was limited to the ascending aorta. So, okay, that was first good thing. Second good thing was we thoroughly evaluated the aortic valve. There was no aortic regurgitation. So again, a good news. So actually the TE decided what surgery has to be done, and that surgery was only replace the ascending aorta. Getting in walled conduit was a very difficult thing. Fortunately, they had a conduit available for this patient. They tried to they called in for help. They fixed this with graft in between, interpositioning graft. They left alone the aortic valve. The cannulation again was guided by TE. We could guide that based on the extent. But imagine if the cardiac surgeon had gone ahead with grafting in the RCA. So it would have been immediate disaster. But we can pick up the things quite early with TE. We can guide the surgeons at every step. What surgery needs to be done can also be guided by TE. So that was the take home message.